Give us a minute. Now we are live on YouTube. Now we are live on YouTube and we are also live on TikTok. Thank you all for sharing Araba Otu. I appreciate you so much. And thank you to everyone who is here. Today we are talking about diabetes type 1 and 2. And I'm so grateful for everyone. This has been a dream of mine. I wasn't sure how I was going to do it, but with the love and support from you guys, I've been able to do it, and this is going to continue. This is a movement that we are starting, and this will continue. So I am on TikTok and YouTube Live. So bear with me if you see that I'm not looking at your screen. YouTubers, I'll try as much as I can to look at your screen, but I'm also on TikTok. And today our topic is type 1 diabetes and type 2. We are a little shy of 1 p.m. So you guys should enjoy my favorite song of the moment, because if you don't give God all the praises and adoration, who are you going to give to? Tina. Hey, Midoyase, thank you for joining. It's almost 1 o'clock and we're going to start one on the dot. So enjoy this song, okay? Thank you. Please like and share. Like and share. Akosia pleasure. Thanks for joining. Thank you all. My YouTubers, thank you for joining me on YouTube. Hey. We are going to learn. Message General, Tina, everyone, my YouTubers, thank you. Mitrima Mukela, you and your mom and your family, Mitrima Mupa. And so thank you everyone for joining. And once our song is done, we're getting on. Wow. Oh, my baby. Rita, thank you for joining, okay, on YouTube. Thank you so much. So much love to you. Extra style. Yes, thank you. So, hey, Thank you. Thanks, everyone. The party is not over, but today, thank you all for joining me. My name is JustAbbyRN. My name is Abby, and I go by JustAbbyRN. And today, I'm excited to be starting this TikTok and YouTube Live. So every week, I'll be coming your way, and right after this broadcast, I will post our next topic. I am a nurse administrator. I'm a nurse. Let's start it off with I'm a nurse. I work as nurse administrator, a travel nurse, and also a residency facilitator. I just added on a new position as a patient educator for diabetes. Hi, Abna. You're welcome. Thank you for coming in. I just added on a new position as a patient educator for diabetes, heart failure, and maybe in the future, I might be doing open heart surgery patients. So this is exciting, and I'm very grateful that you're here. A disclaimer, I am not a guru of diabetes. I found out that the way I learn is to teach. And so teaching helps me to learn. And so I'm here as also to learn from you guys and whatever you have. So thank you. We have audience on TikTok, and we have audience on YouTube. I appreciate you all. Hi Chrissy, thank you for coming on. And as we go on, if you have any question, please, I want to be very fluid with everything that I'm doing. And so if you have any questions, I indulge you to wait till the end, and then we can do some questions, and we can do some question banks also. So, like you all know, my name is JustAbbyRN, and I'm here today. This is a weekly live that we'll be doing on TikTok and also on YouTube. So every week I'll be coming your way, and we'll be talking about different disease processes. Hi, in-law. Different disease processes. And this is the reason why I'm doing this is sometimes I'm not able to reach, and I've found out that during my tutoring I get to tutor a lot of people, and I keep repeating the same information that I have. And so I thought the best way is to reaching the masses is to put things out there. And if you need a very precise and concise, well tailored education documentation, anything that you need me to do personalized, you can reach out to me. Today's session is going to be an hour. You can reach out to me, and then we can talk on how our tutoring services is like. So thank you for joining me. Our first topic, and this is our premiere, this is our first live, and it's going to be on diabetes, type 1 and 2. Coincidentally, I just happened to just get a new job as a diabetes educator. I did not plan for that, but we give God all the glory. So, what do we know about diabetes? And for the purpose of this session, I am going to talk about the pathophysiology of both type 1 and type 2. And by the time I'm done with that, we all know the differences between type 1 and type 2. If you know anyone who is writing NCLEX, this is going to be a good educational session for them. So let them join, because we are, even though I'm tackling the thing as a tutoring service, I'm also targeting our in-class people. That is why at the end of the session, we are going to do our question bank, so that we can deliberate on some of the questions, in-class-like questions that we've put together. So yes, by the end of this, pathophysiology of type 1 and 2, the clinical features of type 1 and 2, of being a diabetic patient, some clinical intervention. I have my muscles here for medication administration, some of the nuances with that, some medications, how to give the shots and all that. So hopefully in the next hour, we'll go through and through to this and be able to give a good explanation. And by the time we are done here, it is my prayer that you leave in this session with a good knowledge of diabetes, and you'll be able to answer any diabetic question. So it's 1:06, and let's begin. All right, so what is diabetes? I have my notes written down, so if you see me looking down, it's because of my notes. Okay, I've got my notes here, and I want to make sure that I am thorough and I'm giving you the right thing. So diabetes is a metabolic disorder. When we say someone is diabetic, it means that they have an abnormality in their system. And the abnormality is that it is contributing to either insulin resistance, that is, you're not able to make insulin at all. You are able to make some kind of insulin, and completely not being able to make insulin. So diabetes is an abnormality, it's a metabolic disorder that is characterized by insulin deficiency. Insulin deficiency is going to be our type 1 diabetics. They do not make insulin at all. They don't have it. Their pancreas do not make it at all. Then we have the insulin resistance, that will be type 2. The first thing I would like to do is to talk about the type 1 diabetes, because After that, the disease process continues to be into type 2, and type 2 will also give a whole type 2 is longer than type 1. So I want to tackle type 1, and then through that education, we branch into type 2. Thank you so much for being here. All right, so type 1 diabetes is it's an endocrine disorder that is usually characterized, we usually see them in young adults or childhood. So they are usually diagnosed when they are kids, or they are in that young adult stage. I have also seen that there's some type 1 diabetics that also comes by disease processes. So when there are some diseases that will affect the some organs, and most importantly the pancreas, that brings out the insulin that will stop that. So type 1 is an absolute deficiency. You do not make insulin at all. And so for type 1 diabetics, we are monitoring their sugar constantly. And because they are little ones and people who are young adults, their education will be different. Parents will also come into that education. Okay, thank you. So everybody needs insulin, and our body do make insulin. Now, whether the body is able to make enough insulin for the glucose in our blood, it's also another thing, and that is when diabetes come in. With type 1 diabetics, their body do not make it at all. What are some of the clinical features you see in a type 1 diabetic? The onset, like I said, is with young adults and children. Typically, they look very thin because that kid has gone on a couple times without insulin. So, and because of the hyperglycemic symptoms, they look typically thin. That and it looks like they've not been fed, because they are not, the energy is not being fed. Glucose is not being able to transcend into and produce energy for them. So we see the weight loss, and also see the 3Ps. The 3Ps is polyuria, polydipsia, and polyphagia. When we say polyuria is urinating a lot. So we see kids urinating a lot, peeing a lot. Then we have polydipsia. They are always thirsty because they are urinating, they are thirsty. Then polyphagia, they are very hungry. Because let's think about it as a house. Our body is a house, and we have people in. We need a key that will feed into that house and help people in that house get stronger. Now, because of excessive amounts of insulin in the body, it is not able to transcend. So yeah, we are not able to feed energy into the system, and so the body system is always hungry because there is not enough energy. They are hungry. There is not enough food getting into them. Then another thing that we see is ketoacidosis. Ketoacidosis can be a complete topic on its own, but one of the things that you realize with kids with diabetes type 1 is a small respiration. That is fast breath and deep breath. So they breathe like this. Yes, that is the small respiration, and it ends up getting them into a acidotic state, because of how they are hyperventilation. And they also have fruity breath. So when you're the kid, it's like, when no born to say ekutuo, they have that fruity breath. Another clinical feature is blurry vision. They will start having blurry vision because what is happening is blood glucose is not, it's because blood glucose is in the system. The eye retinas are not able to work as they should, and that creates that damages the lens of the eye. nocturnal enuresis. They are peeing a lot. Nocturnal enuresis is when a kid or someone's in the night pees a lot or pees on themselves. Then vaginal candidiasis. We see vaginal candidiasis because sugar attracts microorganisms. So that is how we see they kind of like attract it. So bacteria and fungus are able to grow in places that they are not supposed to be grow. So when you have, what would be some chronic management of a patient with type 1 diabetes? Chronic management, consistently eating, because for those kids, remember we said they have polyphagia, they are constantly wanting to eat, they're hungry, so you're feeding them in bits, because as we are controlling their sugar, we are also making sure that they don't drop too low. So because they'll definitely be on a long-term insulin. So these patients are on long-term insulin because their body, remember, their body is not able to make insulin. So this is long-term. Now, so they are consistent. They consistently need some meals and snacks. So small bites, and because we want to give them energy, we want them to not lose weight. And because the body is not doing that, they can lose weight fast. Then we also have giving them a balanced diet. So in as much as we are doing all the snacks and all that, it has to be healthy for them. We are frequently monitoring their glucose levels because we know, especially with kids, they have high energy. So with high energy and with all the activities they do, the more you work out, the more you lose energy, the more your sugar drops. So we are making sure that they are requiring the right amount of insulin. And with kids like that, you realize that we are giving them, their insulin will change based off on their date. A 98-year-old diabetic and a type 1 kid diabetic will be different. Different type of insulin to be given because this kid has high energy. The 91-year-old or 90-year-old will not, so their insulin dosing will be different, and that is when doctors and endocrinologists come in to help with that. So they will be continuously monitored to make sure that they are not going into a hypoglycemic state or an hyperglycemic state. The hypoglycemic is when your sugar is below 70 millimeter per deciliter. Then hyperglycemic stage will depend on what the numbers are. DKA, like I said, is there, and HHS. I'll get into hyperglycemic as a main topic. So type 1 diabetes is they do not make insulin at all, and we see that in children, and we also see that in young adults. Sometimes we will have type 1 diabetics at a later stage of their life, and that will be as a result of medication, sicknesses, diseases that might have affected the pancreas, that will stop the pancreas from producing insulin at all. So in that case, they become type 1 and become insulin dependent because remember, their body is not making any insulin. We also, with type 1 diabetics, or with any kind of diabetic, you really need to have some glucose tablets or anything that gives has a high sugar concentration, 15 grams or more. They have to keep it closer with them. They keep dairy, and you also have to keep tabs of all their sugar levels, like writing them down to make sure that for providers to see their levels and how they can manipulate their insulin production. They require changes with age. So for a type 1 diabetic who was diagnosed at the age of 2 would not be requiring the same insulin as a type 1 diabetic who was diagnosed at the age of 5. So the more they grow up, the more their insulin administration changes. So we will see that these kids will be seeing endocrinologists frequently because of that, because their height, their body weight, and all that, the BMI will also come into play. Now, in when it comes to administration of insulin, I feel like it goes the other way. Everyone, they're being taught, the teaching is the same. So I will save the teaching for diabetics type 1 and type 2 and put that together. But with that being said, I want to talk about one teaching for type 1 diabetics. They are young adults, they are young children. So they get to a certain stage that you want them to be able to administer it themselves or by supervision. So you are teaching them. It's not like parents is always doing that, but you're teaching them on how to do that. Hi, Island. Or is it Island? We carry a source, as a parent, you carry a source of protein with you at the same all the time to give to that child. They will need extra food when a child is exercising. So if you have a child who is type 1 diabetic and they are going to maybe a karate class, they are getting more insulin. You're getting more food with them because they have a chance of going down into a hypoglycemic state. So you make sure that you're giving them more food so that their sugar level will stay as it should. All right. So once we have that, let me see. So for children also who are type 1 diabetics, when they are sick, when they are not eating right, parents will say that, oh, she's sick, so we are stopping, we are not going to give them insulin. When a child is sick, they still require insulin. Check their glucose as you're checking more often, and then offer their glucose to them. So that being said, I think I've been able to talk about the 3Ps and other clinical features of type 1. We will delve right into type 2, and that will give you more better understanding about the disease process of diabetes. Okay. If you're just joining me, thank you for joining us. So, type 2 diabetes. Type 2 diabetes, this is the pathophysiology of type 2 diabetes. Remember, type 1, the body is not making it at all. In type 2, the body is making some. It could be that the body is not making enough insulin, or the insulin is not working as it should. So the body is still making it, but it's either not enough or it's not properly administering it. So that is a major difference that for NCLEX, those who are about to write NCLEX, this is something that you should know. It's a major test question. Now, let's talk about the pancreas. The pancreas is the main body part that makes insulin. The pancreas is still making insulin in type 1. There's a lot of body parts that get affected in insulin or diabetes management. And we have the pancreas, we have the brain, we have the liver, we have the muscles, we have fats, and we also have GI and kidneys. So all of these are working to help with insulin administration. Now, the metabolic abnormality contributes to this insulin resistance, and glucose goes through the bloodstream. But when the insulin isn't able to take it into the cell, then it makes the glucose stay in the bloodstream. So now we have a lot of glucose in the bloodstream. And that is when you check their sugars, you check their finger sticks, it's going to be high, or when you do lab works on them, their sugar is going to be high. And that is what we call hyperglycemia. So hyper is high and hypo is low. Diabetes it can be managed, but curing it permanently is when your A1C is below a certain number. So we will talk about that. People say they have been cured of it, but they really haven't been cured of it. They've managed it to a good state. Someone was asking on YouTube if diabetes can be cured permanently. Normally, the pancreatic beta cells are able to produce enough insulin to correct this. But after a while, so because there's a lot of sugar in the bloodstream, the pancreas that is producing the insulin is able to help. And this is the reason why some people go a number of years without being diagnosed with type 2 diabetes, because they don't know, because the insulin, the body is correcting it. But for how long would our pancreas correct the beta cells in our system correct this? After a while, it gets tired. It's like, I can't do this anymore. I've been doing this for the last 5 years. I am tired. So then the symptoms start showing up. So when it can do that, it can keep up, it starts showing. The liver will respond to the amount of glucose in the blood. So that is why the liver is connected to it. Whilst the liver is responding, it's putting pressure on the liver. And so at the end of the day, we see patients like this ending up getting CKD or AKI, chronic kidney disease or acute kidney injury, because of that. And whilst in this, we will talk about hypertensive patients as well. So now we know the disease, the pathophysiology of type 2 and type 1. What are some risk factors? We stand at risk. What is our genes doing in all this? So one of the things is one of the things that we have two factors that affect someone getting type 1 diabetes or type 2. We have modifiable factors and we have non-modifiable factors. The non-modifiable factors are factors that we cannot change. It is something that we cannot do anything about. And the modifiable factors are factors that we have a hand in it and we can control it, so that either we are not we will not be diabetics, or we can control our sugar levels. So now let's talk about the non-modifiable factors. The non-modifiable factors is age. For anyone above 45 years, you have a high chance of becoming a diabetic. Age is one. Family history. If you have a family member who is directly, if your stepmother is diabetic, it doesn't mean that you will be diabetic. But genetically, if you're connected to someone who is diabetic, you have a higher chance of being diabetic. So your mom, your dad, your siblings, your cousin, grandma, anybody genetically connected to you is a diabetic, you are at risk to becoming a diabetic. History of gestational diabetes. So for us women, when we are pregnant and they do the glucose testing and we have gestational diabetes, this puts us at risk of becoming diabetics. Yes, because it is genetic. Someone was asking on our YouTube page if that diabetes is managed well, will it still pass on to yes, because our DNA, and because of the DNA and genetically we are exposed to it. So that is controlling it, but you are genetically exposed to it, and so it's in your genes and you can have it. Okay. And as like I said, some side effects of diseases can put you at risk for being diabetic. Now let's talk about the modifiable diseases. Modifiable diseases are being overweight or obese. So factors modifiable: overweight and obese. If you're a bit larger in size, you are at risk of being a diabetic. If you are physically, you're not inactive, you are at risk of being diabetic. Hyperlipidemia, you have high cholesterol, that puts you at risk for being a diabetic. Hypertension affects the pancreas because of what? Vasoconstriction. Vasoconstriction decreases perfusion to the pancreas, which makes the pancreas not function as it should, and that causes that will put you at risk for diabetes. I will say this: diabetes, hypertension, um, kidney disease, they work hand in hand, because as we mentioned here, we have that I stated earlier on about how it affects the liver, the muscles, and GI, and all that. So these diseases, once you get one, you stand at a higher risk of getting another. So I always tell people, manage your blood pressure, because once you start getting high blood pressures and you're constricting, you are into vasoconstriction, the vessels are constricting, you stand a chance of becoming a diabetic, because your pancreas is being affected and it's affecting everything else. The same with cigarette smoking. That is a modifiable factor. You can put a stop to it. People who smoke, also, we are going back to vasoconstriction. You are causing inflammation and vasoconstriction to your blood vessel, your heart vessels, and that will cause you, will put you at risk to being a diabetic, because vasoconstriction, like I said before, damages the pancreas. So now that we've talked about our risk factors, our next one is going to be our clinical manifestation, what it is. Remember, I mentioned that it can gradually creep up on you. Yes, most people are walking around with type 2 diabetes and they don't know anything about it, because usually they are fine. Their body is used to being in that hyperglycemic state. Now, when it doesn't get that anymore, when the beta cells, remember, are tired, then they come into it and it's like, we cannot do it anymore. So you start having some symptoms, or sometimes you wouldn't even have any symptom. You would just happen to go to the hospital for something else, and then they'll check your sugar and it's like, oh, this person is really in DKA. They might have come in for abdominal pain, but their sugar is in the 500 because of that. So that is the clinical manifestation. Gradual, asymptomatic. Asymptomatic is when you don't have any symptoms of whatever diseases, whatever problem is going on in your system. You are asymptomatic, you don't have symptoms, and you can go on for years. Just like type 1 diabetes, type 2, they also have the 3Ps. And the 3Ps, for those who just joined us, I'm going to go over the 3Ps. We have polyuria, that is excessive urination. We have polydipsia, that is excessive thirst. And we have polyphagia, that is insatiable hunger. Now, how does this all come about? This is caused in the blood stream. So because blood, we have so much glucose in our blood, we are always in the hyperglycemic state. And when you get into that state, our like we are in an osmotic state, our osmotic gradient is high, and that will cause water to pull, that is water is being pulled into the blood. And once we are pulling water into the blood, the clients get more thirsty, then they excrete it, so they get more thirsty, and that is why polydipsia, they excrete it, and then they get thirsty again. So polydipsia and polyuria goes hand in hand. You are thirsty because water is coming out, so you are thirsty, and then you want to pee more because there is a lot of sugar in the bloodstream. Then polyphagia, because they are hungry. Glucose try to, like I said, you want to use the house as an example. because there's a lot of glucose, energy is not able to transcend into the body, and so there's just glucose sitting in the blood, but it's not able to keep that energy. So you are hungry because you're not being fed. It's just sugar. It's in the bloodstream. It's not doing anything to you and providing you with any food. Okay. And then one of the other symptoms will be blurry vision. Glucose is in the blood. It's all about glucose in the blood. So you say, we always say blood glucose, blood glucose. Really, it is in the blood, and that glucose gets into the eyes. It gets into your eyes and damages the lens. So when we say someone has cataract, that it gives that similar effect. Your lens are being damaged, and that causes that blurry vision. Clients may come in for different things, like I said, and then their testing will be done and found out that they have type 2 diabetes. So what are the testing? I've been talking about they're tested and they find out they have diabetes. How do we find out that someone is diabetic? The first thing, one of the tests that is being done is hemoglobin A1C. A1C, which is above 6.5. Yes, I mentioned cigarettes and vaping also is the same. Yes, vaping and cigarettes, they all cause that vasoconstriction. For those of you on YouTube, on TikTok, someone is asking on YouTube, Yao Entry. That is a brother right there, always helping me out, right? He's asking what I mentioned cigarette. How about vaping? Vaping also causes vasoconstriction to the blood vessel. Later on in this session, I will get more into details about which blood vessel is really being affected here. So let's get back to testing. Testing hemoglobin A1C when it's above or equal to 6.5%, then you are diabetic. That is when doctors will start talking to you about modifying some things to be able to get down below that. But a hemoglobin A1C above 6.5, equal or above 6.5, is diabetic. Now, this A1C that we are talking about, it takes a good look of your sugar for 3 months. So you do a test, and that test, this is giving us the whole overlook of your sugar in 3 months. So in 3 months, that can it gives us that, oh, in this 3 months, this is what your sugar level was. So yep, hemoglobin A1C, it's for 3 months what your sugar has been for the last 3 months prior to you getting that. Then we have a fasting glucose, which is greater than 120 milligram per deciliter, greater or above 120 milligram per deciliter. So this is fasting glucose. You haven't had anything to eat or drink in 8 hours. Anything to eat or drink in 8 hours, then they do that sugar check. So sometimes when you're going for your doctor's appointment, they will tell you not to eat or drink anything for 8 hours. Overnight, do not eat or drink before coming in for your blood work. When they are checking your blood glucose, it is important that they have that fasting glucose. And if it's above 120 milligram per deciliter, that is, you are diabetic. And this, I know Ghana, they have different numbers, like they do the mmol per liter. That will be 7. So if you're 7 and above, you are diabetic when your results is a fasting glucose. Then we have the random glucose check. That is the random glucose check. You should be able to eat whatever you do, but they will check it, and if it's greater or equal to 200 milligram per deciliter, you are diabetic. There are some providers who will do this testing over a period of time. Okay, let's do it this week. Come back again, let's do it another week, and let me see the averaging of it before I can confidently call you a diabetic. Some providers will do that, but the moment they start seeing its consistency, they can tell you that Either you're getting into that stage, or that's when they say that someone is pre-diabetic. So the random glucose check is not a fasting glucose, and so they expect your sugar to be high, and that is why the cut off is the 200 milligram per deciliter. Okay. Then the oral glucose tolerance test, that is for pregnancy women, where they go in and they get tested on it. So now we've gone through our risk factors. We've talked about clinical features of the type 2 diabetes, and we are now at the complications of diabetes. So there are several ways that you can avoid complications of diabetes. You have been diagnosed with diabetes. What next? You have diligent self-care helps with getting any of these complications that comes with it. And also your risk factors, hypertension, hyperlipidemia. How are we controlling all this also helps you in your journey as a diabetic, or your journey in coming down. So I know you're watching me, so you asked about whether you can be cured permanently. I think this part will kind of give a little more insight on that. So what are some of the complications when you're talking about diabetes? How does it really affect us? We have the macrovascular complications and we have the microvascular complication. So the macrovascular complication has got a lot to do with large and medium blood vessels. So it is affecting, so this is where we see the CADs, that is a coronary artery disease, and we see the PADs, the peripheral artery disease, and we're also seeing a stroke or TIA. Yes, diabetes can cause a stroke or a TIA. And this is as a result of the atherosclerosis of these vessels. So the name coronary artery disease says that there is an atherosclerosis of the coronary arteries in the system, thereby causing CAD. When it is causing stroke or TIA, it is an atherosclerosis of the cerebral vessels. So the vessels in our brain. Remember earlier before about the body parts that gets affected with diabetes or included in this diabetes management and its formation and everything. I did mention the brain as part of it. So our cerebral vessels are also affected, and when it affects that, you can get a stroke or a TIA. Then we have the peripheral artery disease, that is the atherosclerosis of the large leg veins. So those are large leg veins and large leg the vessels in the legs. So you see someone with ashy looking leg, the skin is dry and all that. Those are clinical presentations of that. And I'm hoping that one day I'll talk about peripheral artery disease and coronary artery disease. Now, let's talk about the microvascular complications. Micro means small, right? So this is the complication that diabetes can cause in the small vessels, and this is by long-term hyperglycemia. And we have the peripheral neuropathy. So diabetic patients, when as nursing school, diabetic patients, they always have numbness and tingling in their hand, like fingertips, their toes, and mostly it's like I can feel it. Some of them, when you're doing assessment on them, they can feel you touch them, and that can also bring a whole lot of different things into their life, into their health system. So they can feel their fingers, they can feel their feet, they can feel their toes, because blood cannot get through the small blood vessels. So they have that deficiency and that is a microvascular complication of diabetes. Retinopathy. Diabetics stand a chance of, remember we talked about blurry vision. Down, it is affecting the small vessels in their eyes. So the small eye vessels in their retina is being attacked, and that is when they have the blurry vision. Their eyesight is not good because of that. So some say many diabetes there. Many are bebree, and a diabetes are the bebree. Yes, it brings a lot of things to you if it's not managed. Then we have nephropathy. Nephropathy is affecting the small kidney, the small vessels in the kidneys. So remember, I just said a while ago that the kidneys, the heart, and diabetes, being diabetic, they go hand in hand. If you have one of these, you end up getting one of the any of these two because of how the disease processes work. So nephropathy is because it's affecting those small vessels in the kidney. Blood is not going through them. There is no it's inhibiting the blood to pass through these kidney, and that is how they get the nephropathy. Then they also have delayed wound healing. Remember, there is no perfusion. They don't they don't have going back to the small vessels of the legs. So diabetics do not have good perfusion. The PAD, it's all because of perfusion. The CAD is all because of perfusion. It's not great. And we know at this point that blood in the glucose in the blood is inhibiting all this. So now perfusion is not working right, and so if they happen to get a wound, it is very difficult for that wound to heal. So we have diabetic foot ulcers, they become necrotic. So you see a lot of diabetic patients, even if they have to cut their nails or do anything, they have to see a podiatrist because, like a kwanchan, if anything cut them, it is difficult for them to heal really well. So if that is another teaching, if you are diabetic, you're very considerate and you're watching yourself so that you don't get any of these wounds, because if I get a wound, it will be easier for it to heal than a diabetic. The same wound, the same part of the body, it will be easier for mine to heal if I'm not diabetic than a diabetic. So thank you all for being here. Then recurrent infection. Remember, blood is in the glucose. It's a host for all sorts of infections, all sorts of bacteria and fungus. That is why when you have the children, you're talking about the fact that they get vaginal candidiasis because of that. Because their body is a host of all these. The sugar is there. All these fungus, all these bacteria, they are trying to get in there, dig deep, and take what they want to take. And so they do get a lot of recurrent infections. And also, when another complication of it is the DKA, which is diabetic ketoacidosis, I promise you there's going to be it's a disease process on its own that we will talk about. And in the future, I'll make sure that I come back to it to talk about it. But one of the other disease process complication of diabetes that I want to talk about briefly is hyperosmolar hypoglycemic state. So this is HHS, and that is life-threatening when your blood sugar is 600. Yes, people do come into the hospital with 600 milligram per deciliter blood sugar. It is really high. It's also a gradual onset, but when you don't control it, you don't know that you have it for a long time, you walk into the hospital with a 600 reading, then you are at that point you are in the osmolar hypoglycemic state. They have severe polyuria. They are urinating a whole lot to the point that they look dehydrated. They are very thin, and then all the symptoms that come with dehydration is added to that. They have neurologic manifestation, blurry vision, lethargic. They come in very confused sometimes. They don't. They have altered consciousness, and sometimes they are just in coma. Some of them will just be like that. They don't have any energy. Their level of consciousness has been compromised because of that much sugar in their system. The goal when someone comes in with higher sugar like that is to bring the sugar levels down, and we counter that with IV fluids because they are dehydrated. That is how we treat hypoglycemia. Hyperglycemia, I'm sorry. That's how we treat it. We give them fluids to dilute that sugar in their system. We are giving them insulin to bring it down. Now, when you have someone coming in with a 600 sugar reading, you don't want to leave them at that. You want to make sure that they are not dropping from 600 to 100. That is not good. So we are making sure that we are gradually dropping their sugars, and that is why we are giving them an IV drip that is giving them insulin. We will see that we will give them electrolyte replacements because because they are dehydrated. We will see their potassium level low, we will see their sodium levels low, so we are giving them fluid to replace that magnesium. We are giving them phosphorus, so all their levels. When you see someone with any hyperglycemic symptoms, their lab, you're looking at a lab and you're like, what is this? Their lab, nothing is good when it comes to their lab. And then if they come in with that infection because they might have a wound, they're in a septic stage. Their lactate is not looking good. The ED is trying to stabilize them to be able to send to the floor. And usually we see them going to the ICU or going to the step down units, depending on how their reading is. But when they're on a drip, they need more monitoring, and therefore they go to the ICU or step down because a med-surg nurse will not be able to be doing all that. We are checking their sugars every hour. When you have a patient presenting to you with that, you know that you're going to work hard because of cystic, as you should do. Nursing intervention. We are reviewing the client. We are trying to, as nurses, one of our main thing is to educate our patient. So we are teaching them about the understanding of the disease that they just have, especially when it's a new onset. When it's a new onset, we are trying to teach them their disease process, like and for me, how I go about my teaching is tell me what you know as a patient. What do you know about diabetes? And if I know what you know, then I'll know how to teach you what you do not know. Because if I go about, I can waste my time on something that you already know. But let's make it short and good teaching. So tell me what you know, and then thereabout I'll go about it. We have to teach clients how to monitor their glucose by themselves, how to use their, oh, I said I will bring my glucose thing. I won't get up, so, but how to do their finger stick, how washing your hands, making sure that you're not poking the pad, you're poking the side of it, and then we're putting it on a glucometer. We have our lancets that we use. I might post a video of how to poke yourself and check your own. I'll post a video on how to poke yourself and check for your blood glucose monitoring. Now we're going to talk about how to manage diabetes chronically. We will need lifestyle modification. There are some people that do not need medication, anything extra for their diabetes. They just need to watch what they eat and exercise. Remember, we talked about physical inactivity being a factor, a risk factor to getting diabetes. So yes, exercising will help. What you eat, weight loss. Remember, we talked about being overweight and obese as a risk factor. Losing weight will help. Avoiding alcohol. Avoiding alcohol will also help with your blood sugar, because what is alcohol doing? It is affecting our kidneys. It is affecting our pancreas. So it's affecting our liver, and it's part of that body parts that we were talking about earlier on. um, Oral medication. So if all this lifestyle modification, you're doing it and it's not working, then we go into the meds. We go into oral medication, and some people can be on oral medication as a lifelong therapy. That's all that they are using for to treat their diabetes. And some will also use insulin. So insulin is something that I want to talk about it in a bit, because I've got all my insulin stuff that I will be showing you guys. I've got my needles, but I'll get right into that. So now we know that we can do oral. Some do metformin. Some do. They're different. You have the GL1. We have different medications that can be prescribed to help with management, and some would do medicine and the lifestyle modification. After a while, I know your watcher was asking me if it can be killed. Sometimes you can be put on medication, and when it's controlled and you have all this lifestyle modification, doctors are going to stop you. It's like, you're good, your A1C is good, but periodically they'll be checking your A1C to make sure that you're good and the lifestyle changes is helping. So we can have a patient that you're looking at his history, and they usually get upset about it. I'm not diabetic. I'm not diabetic. Yes, you are. At one point in your life, you were. And that, because of that, we will keep monitoring your sugar levels. And so when they come in, even though they are modifiable and they've used lifestyle to change it, we still go ahead to take care, check their sugars to make sure that it is really working. Okay, then our next one, we've talked about our orals and all that. How we are going to, we are also monitoring the person for the hyperglycemic stages, checking their sugars and making sure that they don't go over that. Now, as nurses, client teaching, what are we teaching our clients when it comes to diabetes? And remember, I said that I was going to join the type 1 and type 2. So this, some of it will be beneficial to type 1s, and some of this will be beneficial to type 2. Proper foot care. Remember, we talked about the delayed wound infection and the neuropathy. So they need proper foot care. If someone is diabetic, they are inspecting their feet daily, reporting infections or anything that they see with their foot to their podiatrist or their primary care. They wear protective shoes. So diabetics are always like, they are wearing something to protect them, because if they should get any wound or stand on like a nail or anything like that, they should puncture anything. It is difficult because of the delayed wound infection. It's difficult to heal. So we are making sure that we are helping them. We are buying them protective shoes that will be protect them from any injury like that. We are making sure that they are separating their overlapping toes. There are some people that their toes will overlap, and in time, when they keep rubbing on each other, that can cause a wound. So we are making sure that we are separating them. And now, time and age, there's been a lot of inventions that can help with that separation. We are making sure that when they wash their feet, proper foot care, we are making sure it's dry. We are cleaning it well, making sure it's dry, because sometimes the moisture will cause some ulcers. Okay. Then when they are using it, like, because they've lost that dexterity in their hands, and they also do not have that poor perfusion that we are talking about, when they're going to bath, like hot water or anything, we are making sure that someone else is checking, because their water can be hot, but they will not feel it, and that could cause a burn. So we are making sure that we are taking care of that. Okay. Then The other thing is we're avoiding heating pads. It all goes in hand with the neuropathy and not having feel for their dexterities. So we are making sure that we are avoiding the heating pads with patients with diabetes because they will not feel it. Sick day management. Take insulin when you are sick. When the child is sick and they are type 1 diabetes, check their sugar and give them appropriate insulin. Do not say that, oh, they don't need it. They need it. They need it because stress can cause illness, infection. Stress can cause your sugars to go up. Yes, it does cause your trauma, causes sugar to go up. And so please make sure that when a child is sick, they could be sick, but their sugars will still be high. So please, can you talk briefly about dawn effect? I'm not sure what you're talking about, Pearl. So that will help if you are routinely checking and giving them insulin. Do not stop. Oh, hold on, guys. TikTok is trying to. TikTok is trying to block me. Okay, sorry. TikTok was trying to cut off my live. I don't know. They said I wasn't moving enough. Anyway, so yes, give them that insulin when they are sick. Routine eye exams. So for the children, we are saying they have to have routine eye exam. We have to check their eyes. Retinopathy. We are making sure that their eye vessel, because blood is inhibiting into those small vessels, we are making sure that we are checking the eye, and also stress reduction technique. We are reducing that stress because stress can put you in a hyperglycemic state, preventing infection, systemic infection, keeping up with immunization. So with the dexterity, someone is asking on TikTok, with the dexterity and loss of sensation, is it for those with uncontrolled diabetes or all patients? Mostly uncontrolled, but why are they being diabetics if they don't do their regular checks and they are not found to be diabetic earlier on, and those might have been damaged by the time they are diagnosed. So it can come back with steroids and other things can help it come back. It will help, but at the end of the day, there's some damage. So there will still be those numbness and tingling. But if you have it for a long time, remember the type 1s is a long time, and if it's not controlled and you're in a hyperglycemic state for a long time, you end up you lose it. And once you lose it, really those nerves are already damaged. So yeah, you're welcome. Then keeping up with your immunization is very important. Remember, I talked about getting wounds and like wearing those protective shoes so you keep up with your immunization. The tetanus is one of them that needs to be kept up very well. Tetanus. Tetanus. So tetanus is one of them that needs to be kept like for you to keep up with. And also your pneumonia vaccines that is already given at some point due to age. But I realized that when you get a new admission, that when you're doing admission questions on them, they ask if the person is diabetic. They tell you to ask the person about their pneumonia shot, whether they've got it. So they run the pneumovax and all sort of diabetes and the pneumonia vaccines. So they need to stay keep up with the immunizations, their COVID boosters, everything, because diseases, sicknesses can affect the sugar real quick. And so we are making sure that you're keeping up with all other things so that you don't get sick to let things affect it the other way. That is the thought process behind all that. Let's make sure we are preventing them from getting sick, because when they get sick, they have a lot of things that we have to look at. So yes, that will be for. I'm almost done, guys. That will be for that. Then we are also looking at dietary management to help with proper glucose control. How are we controlling it? We are eating high fiber food. We are eating low fiber, low fat. No, high fiber, low fat. We are also low. We are making sure that our glycemic index is low. So no starchy like we are non-starchy vegetables. They can be cooked or not cooked. Greens, we're eating greens, but greens with high fiber. Beans, oh, that's why I love beans. Gobe, eat the gobe because gobe is good. The lean meats, we are realizing that we are eating lean meats, and the lean meats, we have the fish and chicken. Meat, muna munu ya mudana mo some we friends say approach nam. If you're diabetic, you have to be very careful with all that. So we have lean meat, fish, and chicken. Fish and chicken is what you're supposed to go. And even with that, grilled as to and the other one, frying. Grilling, baking instead of frying, please. Then dairies, we are making sure our dairies is no fat or low fat. So we are going for the skim milks, and we see that with diabetic patients. They come in and they are diabetics because they want all the good stuff, and that got them into that state in the first place. But drinking diet milk, like in my house right now, we don't eat sugar. We eat artificial sweetness. So we don't eat sugar at home. What we eat is as artificial sweetness, because we are trying to limit our glucose and our glucose consumption. Now, the last final thing that I wanted to talk about is the insulin education. So insulin is used to treat diabetes, and we have short acting, long acting, and intermediate. Yes, we have short acting and long acting, and I want to talk about insulin. So bear me, and let's talk about this real quick. So talking about long acting, I want to open up some questions that we will be talking about once we are done here. Once we are done here, we'll be talking about that. So short duration, and that will be our rapid onset. So rapid onset, we have three of them. We have the insulin Lispro. Usually each one of them has insulin in front of them, except for NPH. So I'll just say their second name. You have the Lispro, we have Aspart, and we have Gluglycin. And so Lispro, Aspart, and Gluglycin, they are short acting insulin, and these have rapid onset. Rapid onset is when you give it immediately, they do work rapidly. Within minutes, they are working. And we usually give this to patients before they eat, but they are better than sugar. So instead of having that taste, I'd rather do the artificial sweetness than do sugar itself. And the artificial sugar that I use is better. Small concentration, and then I'm good. Rather than using sugar. Someone was saying that the artificial sweetness are not good, but they are better than a chunk of sugar into your food. So I'd rather do that or no sugar at all. But and so we'll do that at some point. So we have the Lispro, and Lispro onset is 15 to 30 minutes. Then Aspart, the onset is 10 to 20 minutes. So this is the onset, means that when you give it, immediately you give it, this is how long it's working. And we usually give to patients before they eat. Ache, you're welcome. Yeah, thank you. So they usually give it before they eat. So depending on how they are checking their sugar, some patients are checking their sugar once a day. Some are checking 3 times a day and at bedtime. So for those who are checking 3 times a day, you check it before you eat and you give yourself a dose. So the Lispro, that is the rapid short acting onset is between 15 to 30, aspart 10 to 20 minutes, and the glucin is 10 to 50. Then we have the peak numbers. So the peak is when the medication is at its peak in your body. So you've given someone 8 units of Lispro. The whole duration, how long Lispro will stay in the patient's body, is 3 to 6 hours. So let me do it by this. Lispro is short acting. It stays for 3 to 6 hours. If you want to write this will be helpful. You can go back to my YouTube. My YouTube videos will be there. 3 to 6 hours. The onset between 15 to 30 minutes, it's working. It peaks from between 30 to 2.2 hours, 2.5 hours. Then it peaks. That is that. Then aspart is 10 to 20. I can make a chart and post it later on for whoever needs it. Yes, I can make a chart for that. 10 to 20. So the aspart is 3 hours to 5 hours. That's when it works, and it's 10 to 20. Then the glucin is 3 to 5 hours as well. It peaks at 1 hour to 1.5, 1.5 hours. Then we have the regular insulin. The regular insulin is what we usually like. It has the big R on it, and that is the onset is 30 to 60. Then the peak is 1 to 5, and the entire duration could be between 6 to 10 hours. Okay. The other thing is intermediate duration, the intermediate one, and that is the MPH. So this is my own NPH that I made. And we can tell that it is cloudy, but it's settled at the bottom here. So you can tell it's cloudy, it's settled at the bottom here. And this is my regular insulin, Lispro. All the insulins come in clear except for this MPH. So you will not find any other insulin that is cloudy except for MPH, okay? Then I have my muscle that we are going to, I have my muscle fat sub-Q that we're going to use for that. But I just wanted you to see how this is like. So when you're giving a patient NPH, and you pick it up and it's like this, and you draw it. I have my needle here. You draw it. If you just draw it like this, you are not giving the patient the right concentration of insulin. If you draw it like this, you're not giving the patient the right concentration of insulin, because this is the only one that is a suspension, okay? So you have to shake your insulin. I'm saying this because it might sound really basic and something that someone should be able to do, but I tell you, people are not so make a mistake and just pick it up and draw it. You really have to shake it well and then draw. And when you draw, it's good for 15. You have to give it within 15 minutes, especially when you're drawing it together with this. If it's a regular and an NPH, you have to do it fast. Give it to the patient fast. You can do this and let it sit for 30 minutes. It will lose its potency, okay? Then we have the long duration. The long duration is, that's what typically we know the Lantus as long duration. You give it and that will last long. So that is lasting. Go to Mama. That will last for we have the Lantus and we have so the Lantus will last for 60 to 120. Hang on. Sorry about that. So, the Lantus is 70 minutes, and that is the onset, and that is given in such a way that it would deliver small doses. We are delivering small doses over an extended period that could be between 18 to 24-hour period. And some even go, we have one that is called Declodec that takes like over 40 hours. So the Lantus is what we give overnight, or it can be given in the morning. It takes care of you for 24 hours. And that is like a fixed amount that your provider will give out to you. So the long duration ones are the Glugen, Detramer, and the Degludec. Intermediate is MPH insulin. Okay, and this is the MPH that we did talk about. Now, I'll just like to briefly demonstrate how to give this. So, we have our alcohol swab. We are making sure that we are preventing them from getting infection. So, we have our alcohol swab, we have our needle, and we also have our insulin. If you're giving MPH, we are mixing. Let's say we are mixing insulin. We are making sure that we are drawing the regular first before we draw the MPH, because we do not want to put a needle that has been put into the MPH, a needle that has been put into MPH. We don't want to thank you, Evelyn, thank you. We don't want to put that into the regular insulin, okay? So our first attempt is to draw the MPH first, and then we draw the later on I'll put down some mnemonics for you, and then we draw the regular. Okay, so what we do, no, my bad, we are drawing the regular and then putting that into drawing the MPH, because we don't want to contaminate our regular. So we draw the regular, then we draw MPH. Okay, so whatever we're giving, let's say we're giving 10, we're given 10 units, so we put that in here, we draw our 10, I don't know why I took my lid off, but we put our air in it, then we draw whatever amount we are drawing, and then we come into our MPH, which we've shaped really well, and we put that in, and we draw whatever amount that we need to draw. And now we have it. We are going to, I'm taking it back. It's like I'm doing this myself. So let's say we are doing just 10, which is 50 and 50. And so we do this and we prime our needle. It is very important to prime your needle, and we give it. So this is the regular insulin. I had this that I bought, and you give it to your patient. I'll show the administration, but I have this that I bought, that this is an insulin pen, and usually the Lantus will come in insulin pen, and there's a dialer here. And if you can, I'll show it to you TikTokers, but if you can see, these have numbers, and that is how you dial your insulin that you're supposed to give. This is for demo, so it doesn't have any insulin in it, but in the future I'll show you videos of it. But we have a dialer, and this is how we dial our units, and then you administer it. And when you're administering it, you have this clean, and you just put it in, and then you push it down. You have this clean, you push it down, and you give it to your patient. Okay, This, I believe, can take a whole session. Okay, so this, if you want to see more video, I believe I can do a video on this demonstrating it really well. But that is our insulin. You give it, and you give it in the skin. Where do we give our insulin? We give it, we have different landmarks that we can give our insulin to. So it's what are some of the landmarks for subcutaneous insulin? We are giving it in the upper back, but mostly you cannot reach it yourself to give. If someone is giving it to you, that is fine, but subcutaneously you can give it in the upper back. You can give it in the lateral aspect of your arms. So we are looking at this side, and usually it depends on the skin. So if you have a patient who is thin, when you're giving it in the skin, you're just also making sure that you're not touching the bone. Yeah, there are some patients that you might give it in the bone, if like you might poke the bone. So we are looking at because it's going into the subcutaneous tissue, so the fatty part. Okay, so we're making sure we're putting that in the fatty tissue. You can give it in the belly. Most people self-administratively can give it. Most people can give it in the belly. Self-administratively, when you're giving it to yourself, it's convenient to do it in your belly. So you just hold a good portion 2 fingers away, like 2 inches away from your umbilicus, and then you've drawn your insulin, and it's a 90-degree in. 90 degrees. So 90 degree, you're just giving it like this. You put it in 101, 102, 100, 300, keep it for 10, like at least some few seconds, and administer it so that you're not in a rush to take it out. Especially with the Lantus, like the pen, some people will put it in and they'll not finish with pushing, and then they'll take it out. So when you have something like that, you just make sure that you're saying we are counting to about 10 seconds, then you take it out. So you can give it in the belly, you can give it in the thigh, the lateral part of the thigh, you can give it, and you can also give it in the anterior part of your thigh. So lateral, upper arms, and you can do all that. So here, your thigh, upper, lateral, or wherever that you can get that tissue, we're putting it in the fatty tissue. So we're making sure that the subcutaneous tissue, that's where we're putting in. So you're grabbing enough. I did say 45 degrees, but when you're giving it and the patient is very thin, you can go at a 45-degree angle, okay? I said 90 earlier, but depending on how the patient is, you can go on a 45-degree angle. Now the needles. For insulin, we have the 28 to 31 gauges. This one is a 31 gauge. And look how thin is it. It is. This is a 31. They are very thin. Where's my camera? Yeah. They are very thin. I just want to make sure I don't poke myself. They are very thin, okay? So this is 31 gauge. I only have the 31 gauge. And this is 1 ml. And this is 50 ml. So depending on what you're given, that is when you take a needle that will fit it. If I'm giving a straight out 10 units, I can use this because it counts in ones. So it's easy to get 10 on here. If I'm using a 10 unit, I can use it because it's easy to get a 10 units on there. Now, if I'm trying to give someone 1 unit or 2 units, it will be difficult for me to use the 1 ml. So in this case, I am going to use the 50 ml to give a patient. No, I'm not selling them. I'm using them for demonstration. These are not these are not insulin. These are not insulin. This is water. This is milk with water. Someone is asking if I'm selling them. Pearl, I'll briefly talk about the hypoglycemia, okay? So 5, if I'm giving 2 units, the 5 ml, the 50 the 0.5 ml, I'll be good giving it with this. Even this is also a 31 gauge. Okay. Yep. I'll be good giving that with it because of how small it is and I can see. And this moves, it moves around. So if it's covering your numbers, you can just move it around so that you have proper view of what your numbers are. And also with the administration, I said 2 inches away from your umbilicus, and it's up, down, and side. Usually, we educate that when you're giving it, make sure you have a good grip of the skin of the patient, but rotate sides. So we are rotating sides. You don't give it at one spot. We rotate sides. So when you give it here, you make sure that you are documenting that where you're giving it. Documentation is very key. We are documenting where we're giving it so that we rotate side, because poking severally will cause scar tissue um, issues. So there will be a scar tissue there. And imagine that there's underneath the skin there's a scar tissue, then you keep putting insulin in the same spot. The patient will not get that 2 units or 3 units that you gave them because you're giving it in the same spot and there's a scar tissue there. So we try to move around and rotate sides, okay? Because we are also thinking about infection. You don't want to keep poking one side and keep poking one side. We don't want them getting wound. We have seen many times with patients who are getting all these new medications that they come in with necrotizing fasciitis because they keep poking themselves, and underneath it is a lot of inflammation there. So try as much as you can. You have to rotate side, and if you're giving it yourself, try also to rotate sides. Okay. Um, so that is it with the administration. We've talked about the administration. We've talked about pills. Now let's talk about hypoglycemia. But I've been talking about all these medication, giving it and everything to control it. But briefly, I want to talk about hypoglycemia. Hypoglycemia is when your blood sugar is below 70 milligram per deciliter. And this is another complication of diabetes. We are bringing the sugars low because we are giving all that. It is recommended that when your sugar is below 70, you are in a hypoglycemic state. And if you're in the hospital, we are doing the hypoglycemic protocol for anyone like that. So we are giving you glucose or something to help, peanut butter or sandwich, something to help you get your sugar reading up high. So once we have that, then we are taking that into consideration because we're giving all these insulin. So we are watching the patient for what? What are some of the signs and symptoms of hypoglycemia? They become irritated, like very irritated. They are irritated, like it causes irritability, diaphoresis. They are very diaphoretic. They are sweating. They are very dizzy. They feel dizzy. And they've been sugar now from. They are very dizzy. They are very dizzy. They have tremors. They are weak. They are drowsy, and if they are on a monitor, we can see that their heart rate is going really fast, and they also are very hungry. So in as much as we're talking about how it goes up and everything, this is the state of hypoglycemia. Below 70, we treat that. If a patient is not with it, cannot eat or drink, it's in coma, it has been intubated, and for that matter, you cannot treat it. We can give IV glucose. We can also give them IM glucagon. That is when they are very hypoglycemic. We give them IM glucagon, where we push medication into their intramuscular. So that is it. Pearl, if you're still on, Did I talk about the hypoglycemic state for you? So I know you were talking about the, is it Smoji? Oh, yeah, when you said down, I thought you were dawn. So okay. Yeah, so that is, we have the dawn effect where at night people their sugar, by the morning their sugar is like really low, low. They go into a hypoglycemic stage because that is an episode that happens overnight. And it is something that you can see a lot, especially with patients that do new onset, and we are kind of like managing them. You see that a lot in patients like that. So I have been able to talk about type 1 diabetics, disease processes, and I believe that um, I have been able to give some. If you have any questions, I'm just waiting. If anyone has questions, please, 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 please put it down and let's talk it briefly in the next 2 minutes. I know I said 1 to 2. Maybe I should do 1 to 2:30 because I have covered a lot, and it's probably because we talked about two disease processes that sometimes we just do one. Sometimes we just do just one of them. So thank you so much for sticking with me. My next thing that I wanted to do was to talk about some few questions. um any questions? If you have any questions, please drop down. Oh, thank you so much. I hope it was educative enough. Yeah, I am, I try to bring out something, and so I hope if you enjoyed this, please follow me on my TikTok. This will be a great avenue. We'll be doing a lot of these. If you enjoy these, and um, let's talk about this. I am trying. I am. I am really trying to see if I could get some questions. I have some questions that I wanted us to talk about. And so, one question here. Oh, thank you. Thank you. Island, Georges, or Island. Thank you so much for joining me. I have one question. Let's do this question and then we'll be out. The nurse is taking care of a parent of a 7-year-old client with newly diagnosed type 1 diabetes mellitus. Which of the following statements by the parents will indicate effective coping? Our child may not be able to participate in sporting activities. Our whole family is willing to make sacrifices for our child's health. We will make separate meals for our child to accommodate their dietary needs. Or we are working to manage this condition so that our child have an independent life. For a child with type 1 diabetes, we want to manage we have to manage their condition because it's a lifelong condition. So for a parent, yes, yes, girl, yes, yes, girl. For a parent to say that we are working to manage this condition, it means that parent is coping well with it. Parent is coping well with it. We will make separate meals for our child to accommodate any dietary needs. No, this is not an allergy. This is not an allergy. So that child can eat in moderation what they are supposed to eat. Remember, we are feeding them because they are thin looking. Our whole family is willing to make sacrifices for our child. This is not something that you have to make sacrifice for. You are treating, you are helping manage a disease. Remember, prolonged insulin. They're on a life for life. They're on some management because the body is not making it at all. Once our child may not be able to participate in sporting activities. No, when we did the type 1 diabetes, we said that they can be able to participate in sporting activity. They can do all these things. Just remember that it can put them into an hypoglycemic state where we see symptoms like diaphoresis, weakness, dizziness, hunger, tachycardia, shaky, tremors, because they've lost a lot of energy and shock. And so we are making sure that we are replenishing that by giving them small food. They are eating enough. And we also talk about the age difference. If that child is 5 or 3, their insulin requirements will be different from when they are 9, when they are 10. So this is going to be a lifelong treatment, and we as a parent you have to manage. They can perform, they can do all sporting activities, they can go for the walks, they can join the football team. It is not something that will not, you have to take their childhood away from them. You have to help them manage it. So yes, as a parent, your child can do a sporting activity while they are a type 1 diabetics. Um, I wish we could go on and on and on. But one more. The nurse is talking with a parent of a pediatric client with type 1 who has influenza. Which of the statement by the parents would require follow-up? I should encourage my child to drink more fluids. I will check my child's capillary blood glucose level frequently. I should regularly check my child's urine for ketones. Yes, we are checking for ketones. We are periodic checking for ketones because ketones are produced when the body cannot use the glucose. So when there's more glucose in the system, that is when the ketones are up, and so they will need fat to break it, and that can sometimes put them into DKA. So we are checking for that. And the last one is I would decrease my child's prescribed dose of insulin if my child is unable to eat. The nurse is talking to the parents. Which of the following statement but it will require follow-up? You don't decrease it when your child is sick, when your child is unable to eat. You don't decrease it. You check it and give insulin as you should. So, thank you so much for joining me. I appreciate you all. YouTube, you blew my mind. TikTok, you've blown my mind. Thank you for being amazing guests. And next week, I'll post what we have to do next week. But I appreciate you all and thank you for sticking with me. This has been very, my first live has been very, I've gotten a lot of support and I'm excited. So I leave you all. Abena, I hope this was good for you, okay? You are one of the reasons I'm doing this. So let's enjoy this. And thank you, everyone. TikTok, thank you, Atre. I appreciate you guys. Every week we will be coming on with a disease process. And next week, I will post the date and time. And we will talk about this. We talk about a disease process. We are going to pass NCLEX. So if you're writing your NCLEX, this is the place to be. Tell someone when I post my dates, tell someone to join and let's learn. I am learning and you are also learning. So let's end. So with this, I will leave you with my favorite song. Thank you so much. I appreciate you all. Enjoy the music, and I'll see you later. Tina. Thank you, Tina. Please follow. Subscribe to the YouTube, okay? Thank you, message. Thank you. Thank you. And it will be on YouTube. It's going to be on YouTube. So if you want to go back to it, you can go back to it. And if there's any request, anything that I have to do better, please, I'm not a saint. I don't know it all. Talk to me. Let me know what things I can do. Oh, sorry. Thank you. Let me know the thing. It's on YouTube. So go to my YouTube and watch it. Let me know what I can do. And to move forward as an educator, I need to better myself. So any suggestion, any criticism, I'm here for it all. I love you all and thank you so much.